Hello. Today, we're tackling a really critical topic, the anesthetic management of patients with myasthenia gravis. This is a high-stakes scenario, and this explainer is designed to be your perioperative guide. You know, managing a patient with MG isn't just about following a standard protocol. Their unique neuromuscular issues and really their extreme sensitivity to our anesthetic agents, well, that demands a completely specialized approach. The margin for error is small. If we get it wrong, the complications can be severe. But if we get it right, we can safely guide them through a very high-risk procedure. Welcome to the Dr. Mech series, your source for advanced medical education. Just a quick reminder, this content is for educational purposes only. All the information we're going to cover today is based on the StatPearls publication, Anesthesia for Patients with Myasthenia Gravis, which was last updated on March 28, 2025. All right, so here's our game plan. We're going to break this down into 4 key sections. First, we'll look at the disease itself, the myasthenic challenge. Then, we'll cover the crucial preoperative assessment. After that, we'll get into the specifics of intraoperative anesthetic strategies. And finally, we'll wrap up with postoperative care and how to handle potential complications. Okay, let's start with Section 1, the myasthenic challenge. It's all about understanding the core pathophysiology. So, let's get right to it. What exactly is myasthenia gravis? At its core, it's a chronic autoimmune neuromuscular disease. And the key part of this definition for us is that it causes skeletal muscle weakness because it's destroying those postsynaptic acetylcholine receptors. Let's dig a little deeper into the key features here. The pathology is very specific. We're talking about autoimmune antibodies that are laser-focused on those postsynaptic nicotinic AC receptors. This is what leads to that classic fluctuating muscle weakness that gets worse with exertion. Now, for us in the perioperative setting, 2 things are absolutely critical to watch for. First, any bulbar involvement, think speech and swallowing, because that means a huge aspiration risk. And second, any respiratory muscle involvement. That is a major red flag for perioperative compromise. And this is a distinction we have to get right: myasthenia gravis versus Lambert-Eaton syndrome. Look, this isn't just some academic exercise. Getting this wrong could completely derail your anesthetic plan. Just remember, myasthenia gravis is a postsynaptic problem. Their strength gets worse with use, and they are incredibly sensitive to our non-depolarizing neuromuscular blockers. Lambert-Eaton is basically the opposite. It's a presynaptic issue, and those patients are actually resistant to those same agents. So you can see they're 2 fundamentally different challenges in the OR. Okay, with that core understanding, let's move on to Section 2. This is where we take that pathophysiology and turn it into a practical plan, preoperative assessment and optimization. One of the most useful tools we have for this is the Levinthal scoring system. It's designed to help us predict the likelihood that a patient will need postoperative mechanical ventilation. So, the risk factors to watch for are a disease duration of more than 6 years, any coexisting chronic pulmonary disease, a daily pyridostigmine mean dose that's over 750 milligrams, and a preoperative vital capacity under 2.9 liters. Now, when it comes to preoperative medication management, the #1 rule is continuity. You want to continue the patient's home regimen. But, and this is a big but, if you have to switch to a parenteral acetylcholinesterase inhibitor, you have to be really careful with the dosing. The parenteral dose is just 1/30th of the oral dose. That's a critical conversion to remember. And it probably goes without saying, but we have to avoid any drugs that can make the weakness worse. Things like calcium channel blockers, magnesium, and aminoglycosides. And for any patient with bulbar symptoms, definitely consider aspiration prophylaxis. All right, that brings us right into the OR. Section 3, intraoperative anesthetic strategies. And really, this is all about navigating the complexities of neuromuscular blockade. Okay, this is the central paradox you're going to face with these patients. Because they have fewer functional acetylcholine receptors, they are paradoxically resistant to depolarizing agents like succinylcholine. You'll actually need a higher dose. But for that very same reason, they're highly sensitive to non-depolarizing agents like rocuronium. So for those, you'll need significantly reduced doses and some really careful titration. So given that extreme sensitivity, our first thought should always be, can we avoid neuromuscular blockers altogether? And, often the answer is yes. Volatile anesthetics might provide all the muscle relaxation you need. Now, if you do need a blocker, the clear preference is for shorter-acting agents. We should also be thinking multimodally. Using things like regional or epidural techniques can really cut down on the overall physiological stress. And of course, we have to be extremely cautious with any respiratory depressants, especially benzodiazepines and opiates. When it's time to reverse the blockade, Sugamidex is the drug of choice for rocuronium or vicuronium. But here's a critical piece of advice. It is not a magic bullet in this patient population. There have been reports of variable success. So what does that mean? It means our vigilance can't let up for a second. We have to monitor the patient closely for any sign of residual weakness. And the ultimate goal is always a fully awake extubation, but only after we've confirmed their ventilatory function is absolutely adequate. Okay, and that brings us to our final section, Section 4, Postoperative Care and Complications. This is all about managing potential crises and making sure the recovery is safe. Imagine this. You're in the PACU, and your patient is profoundly weak. This presents a critical diagnostic dilemma. Your next move depends entirely on the answer to one question. Is this a myasthenic crisis, meaning they're undermedicated, or is it a cholinergic crisis, meaning they're overmedicated? And differentiating between these two is absolutely essential because their treatments are polar opposites. A myasthenic crisis is a flare-up of the disease itself. Giving them metrophonium in a tensilon test will actually improve their strength. But a cholinergic crisis, well, that's a toxic state of overmedication. You'll see those classic muscarinic effects, and giving edrophonium will only make them weaker. You can see how getting this wrong would be incredibly dangerous. Recognizing the triggers for a myasthenic crisis is really key to preventing it. Surgery itself is a huge trigger, along with things like respiratory infections and changes in medication. You should be especially wary with patients who have a history of a previous crisis, severe oropharyngeal weakness, or the presence of a thymoma. They're at the highest risk for this kind of life-threatening complication. And all of this, it all points to one single overarching takeaway. For these incredibly complex patients, safety isn't about one person's skill. It's about a coordinated interprofessional approach. This is absolutely non-negotiable if you want the best possible outcome. So what does that look like in practice? Think of it like a safety checklist. It all starts preoperatively, with close optimization alongside the patient's neurologist. It means having a detailed, informed consent that explicitly discusses risks, like the possibility of prolonged mechanical ventilation. Then, intraoperatively, it demands continuous, closed-loop communication among everyone on the perioperative team. And post-op, it means active, vigilant management of airway secretions to prevent aspiration. This collaborative model, it isn't just a good idea, it's really the standard of care. You are listening to the Dr. Mimic series. If you found this guide valuable for your practice, please make sure you subscribe and hit the bell. That way, you'll get more evidence-based medical explainers just like this one. We'll see you next time.